Today I'm presenting Miss Sarah Williams, a 45-year-old with relapsing remitting multiple sclerosis. Part 1 covers her presentation, goals, outcome measures, and exercise prescription. Part 2 compares exercise modifications and special considerations across all 4 neurological cases. Sarah is a 45-year-old female from rural Australia with RRMS, diagnosed in 2017. Demyelination contributes to her right-sided weakness, fatigue, and balance impairment. She also has asthma requiring Ventolin as needed. However, because salbutamol can elevate her heart rate, RPE was used as a primary intensity guide throughout the program. Betaseron is her disease-modifying therapy, so exercise sessions were scheduled away from her injection days to minimize post-injection fatigue. Her history of a right ankle fracture also influenced exercise selection, with right-sided unilateral calf loading deferred until phase 3. Using the ICF framework, her primary body function impairments include demyelination, fatigue, and weakness. Activity limitations involve stair climbing, prolonged standing, and sit-to-stand tasks, while participation restrictions affect her ability to teach, attend the gym, and engage in family life. Key barriers include fatigue, heat sensitivity, rural isolation, and low exercise confidence, all of which needed to be managed within a 6,000 NDIS budget. 4 goals were identified: improving stair climbing, standing endurance, weight and confidence, and fatigue self-management. Fatigue management was prioritized as Goal 4 because it underpins and influences performance across all other domains simultaneously. This framework demonstrates the clinical reasoning behind every decision in the program. Exercise can be traced from an assessment finding through a clinical problem to a measurable goal with an MCID before linking to a specific exercise and supporting evidence. As a result, this is not a generic MS program, it is entirely assessment-driven and tailored to Sarah's presentation. You'll also notice the fatigue appears across all 3 goal pathways. Rather than treating it as a secondary issue, it was elevated to Goal 4 because it directly influences performance, participation, and progression across every other domain of function. Goal 1 is stair climbing. Sarah's timed up and go score of 15.4 seconds exceeds the high falls risk threshold of 13.5 seconds, identified by Nilsgaard 2007. Her right side single leg stance of 18 seconds is also well below the age-matched norm of 29 seconds, reported by Springer 2007. Targets include reducing timed up and go to below 12 seconds and improving 5 times sitter stance to 10 seconds or less, both exceeding published MCIDs. Short-term milestones focus on the supervised phase, including 1 flight of stairs with a handrail and improving single leg stance to 22 seconds. By month 12, the long-term goal is independent stair negotiation without a handrail in real-world environment. Goal 2 focuses on standing endurance for Sarah's teaching role. Her 6-minute walk test distance of 385 meters is below the normative range for people with MS and sits 54 meters below the MCID identified by Goldman in 2008. Her FSS score of 40 is also the most clinically significant, exceeding the CROP 1989 threshold of 36. By month 12, targets include a 6-minute walk test distance of at least 439 meters, an FSS below 36 in the short term and below 32 in the long term, and the capacity to teach for a full school period of approximately 50 minutes without fatigue. Aerobic exercise was selected as the primary evidence-based intervention to improve both endurance and fatigue management. Conversations with Sarah were framed around energy, function, and participation, rather than her weight or appearance. Her 15-kilogram post-diagnosis weight gain reflects fatigue-driven deconditioning, not a lifestyle failure. Aerobic exercise was selected because it addresses both weight management and fatigue simultaneously. In Hine 2015 demonstrated significant reductions in FSS exercise, while Latimer Chung 2013 reported improvements in both fatigue and quality of life. For this reason, Goal 4, reducing FSS from 40 to below 32, is embedded with the aerobic prescription rather than treated as a separate outcome. Those short-term priorities focus on attendance and adherence to establish consistent exercise habits, The midterm phase introduces community gym participation once per week. By month 12, targets include independent gym attendance 2 or 3 times per week, a cumulative weight reduction of 4 to 5 kilos, and fully independent fatigue self-management using the pre-session checklist. 4 additional assessments were selected. The 10-meter walk test measures gait speed with an MCID of 0.1 meters per second, making it more sensitive than the 6-minute walk test for detecting short distance change. The Berg's Balance Scale provides a 14-item assessment of dynamic balance with an MCID of 3.29 points. Whereas single-leg stance alone may miss task-specific deficits, the Modified Fatigue Impact Scale separates physical, cognitive, and psychosocial fatigue, providing greater precision than FSS for informing session timing. Peak flow was included to identify exercise-induced bronchoconstriction risk given Sarah's asthma history. In-session monitoring included pre and post-exercise blood sugar due to stage 1 hypertension, RPE as the primary intensity measure because of Ventolin can cause tachycardia, and a pre-session fatigue rating, where scores above 6 out of 10 triggered a 30% reduction in volume and intensity, consistent with CROP 1989 and COS 2008. Safety considerations directly inform program design due to Uthoff's phenomenon. Every session was conducted in a cool environment with a fan and cold water available. An exercise was stopped immediately if neurological symptoms worsened. With a tug score of 15.4 seconds exceeding the high force risk threshold, spotters and floor mats were mandatory during all balance activities. Because Ventolin was taken, we have to take into consideration tachycardia, so RPE was used as a primary intensity measure throughout. Beta-seron injections days were avoided, which was an absolute contraindication, which included acute relapse, blood pressure above 180/110, and active bronchospasms. Relative contraindications included high preseason fatigue and low-grade fever, both of which triggered program modifications rather than cancellation. The guiding clinical principle was always to modify and not skip. With safety established, I will now walk through the 3 phases of exercise prescription. So phase 1 prioritized confidence, movement quality, and exercise competency. To minimize fatigue accumulation, sessions were split into A and B and scheduled mid-morning. When MS-related fatigue is typically lowest, according to COS 2008, session A required a focus on lower limb strength with a sit-to-stand targeting 5 sit-to-stand deficits, bilateral calf raises protecting the right ankle, and bridges and dead bugs improving trunk stability. Session B focused on balance and endurance, incorporating tandem walking, supported right priority single leg stance, 10 centimeter step-ups, and recumbent cycling to build an aerobic base without the falling risk associated with treadmill walking. A fan and cold water were available at every session. A spotter remained on Sarah's right side during all of the balance tests, while timed up and go exceeded 3.5 seconds. Right-sided unilateral calf loading was deliberately deferred. After confidence and consistency is established, we go on to phase 2, which shifts to improving functional capacity. Phase 2 introduces progressive overload. Chair height is reduced during sit-to-stands, while rows progress from seated to standing to increase occupational standing tolerance and directly target goal 2. Calf raises progress to left-sided unilateral loading, building single leg capacity while continuing to protect the right ankle, with right-sided loading deliberately deferred until phase 3. Step height increases to 20 centimeters, reflecting typical residential stair height. Treadmill walking is introduced for the first time, as aerobic capacity and balance have now been established through phase 1. A full reassessment at week 8 is required before progressing to phase 3. Advancement is contingent on achieving the timed up and go MCID of 3.5 seconds. If targets are not met, the program remains at phase 2 until those criteria are achieved. This progression rule is built directly into the program design. Phase 3 focuses on independence and discharge preparations. Phase 3 focuses on translating clinical gains into real-world function and long-term self-management. Supervision reduces to 1 session per week, a deliberate strategy to extend NDIS funding through to month 12. Right-sided unilateral calf raises are introduced for the first time, while goblet squats replace sit-to stands and reverse lunges increase unilateral loading demands. Treadmill incline progresses to 5%, and community stair climbing without a handrail on fatigue days directly targets goal 1. Discharge preparation becomes a clinical priority, including gym orientation, a written exercise program, referral to MS Australia, and telehealth reviews at months 7, 9, and 12. Community-based activities such as Pilates, aquatic exercise, yoga, and walking groups are incorporated because they are both clinically indicated and budgeted, supporting long-term fatigue management, balance, and exercise adherence. The home program reflects the core philosophy underpinning the entire prescription, a gradual transfer of responsibility from clinician to client. Program A reinforces supervised sessions with low-volume exercise on non-clinical days. Program B replaces reducing supervision with greater autonomy and community participation. Program C transitions from a structured exercise program to a broader lifestyle framework. By month 12, the goal is fully self-directed physical activity with independence driven by confidence, self-management, and community engagement rather than reliance on a program card. Program A covers months 0 to 3 and reinforces the supervised phase. It includes walking, sit-to-stands, bilateral calf raises, right priority single leg stance, daily stair practice, and stretching. Sessions are limited to 20 to 30 minutes and remain low volume because Sarah is already completing 2 supervised sessions per week. Program B covers months 4 to 6 and introduces greater independence through goblet squats, step-ups, banded rows, side leg raises, dead bugs, and 20 to 30 minutes of brisk walking. Gym attendance begins once per week using a written program card, while community options have MS Australia programs, park walks, and council groups are introduced. Program C covers months 7 to 12 and transitions from an exercise program to a lifestyle framework. Structured gym and home-based exercise occurs 2 to 4 days per week, alongside 1 to 2 days of community activity. Pilates supports trunk control, aquatic exercise assists with heat management, yoga targets fatigue, and walking groups promote long-term adherence. Daily lifestyle movement forms the third component, targeting 6 to 10,000 steps per day. The $6,000 NDIS budget is distributed across supervised EP, while follow-up reviews, gym memberships, and community activities, creating a 12-month pathway toward independence. That concludes part 1. I will now compare and contrast exercise prescription and special considerations across the 4 neurological conditions, which is multiple sclerosis, stroke, spinal cord injury, and cerebral palsy. To ensure a consistent comparison, I will use 2 exercises from Sarah's program, sit-to-stand and aerobic training, and examine how the rationale, prescription, progression, and safety considerations differ across each condition.
Sit-to-stand appears across all 4 cases, however the pathology driving its prescription differs substantially. For Sarah with RRMS, demyelination contributes to the lower limb weakness and her fatigue. Her 5-time sit-to-stand time of 14 seconds identified reduced functional power, so the exercise progresses from a standard chair to a lowered chair and eventually a goblet squat. Fatigue management and right-sided falls risks are the primary considerations, requiring a spotter on the right, Ventolin access, and cessation if neurological symptoms worsen. For Mr. Roberts, following the stroke, the rationale shifts entirely. Sit-to-stand becomes a motor relearning task rather than a strength exercise. The goal is to restore symmetrical weight transfer through the paretic left limb and improve movement quality. A raised chair and armrest are initially used to improve eccentric control, with verbal cueing encouraging weight transfer through the left heel. Progression is determined by movement symmetry and motor control rather than the load. Blood pressure is monitored due to Metropolo use, and an emotional liability protocol is in place. Mr. Trin is with a T3 Asia B spinal cord injury. Traditional sit-to-stand is not possible. Instead, tilt table standing serves as the functional equivalent, progressing from 20 to 70 degrees across phases. The goals shift to orthostatic tolerance, bone density maintenance, spasticity management, and prevention of secondary complications. Autonomic dysreflexia is the primary safety concern, requiring continuous monitoring of blood pressure and headache symptoms with GTN readily accessible and pressure relieving padding in place. Miss SM with spastic diplegic cerebral palsy, spasticity and co-contraction make the eccentric lowering phase particularly difficult and energy demanding. A higher chair reduces eccentric demand, while tactile cueing assists with left knee valgus control. Progression prioritizes movement quality over external load. A seizure action plan is available. A parent remains present, and forward spotting is maintained throughout. Same movement, 4 completely different clinical rationales driven by 4 different pathologies. Aerobic training is prescribed across all 4 conditions, but the underlying impairment, exercise modality, and progression pathway differs substantially. Selecting the most appropriate modality for each client is an exercise clinical reasoning. So for Sarah, with RRMS, the primary limitation is demyelination-related fatigue and reduced walking capacity, reflected by a 6-minute walk test of 385 meters. Training progresses from recumbent cycling in phase 1 to treadmill walking in phase 2 and treadmill incline in phase 3. The goal is not simply cardiovascular fitness, but improved fatigue management and functional stair climbing capacity. Heat management remains mandatory throughout the whole course, and with a fan, cool environment, cold water, and Ventolin readily available. So for Mr. Roberts, following the stroke, aerobic limitation is driven by hemiplegia, gait asymmetry, foot drop, and increased energy cost of walking. Partial body weight supported treadmill training allows for repetitive, task-specific gait practice while reducing falls risk. Unlike Sarah, the primary goal is motor relearning and gait symmetry rather than cardiovascular endurance alone. Progression is based on reducing body-weighted support and improving gait quality. For Mr. Trin, with T3 Asia B spinal cord injury, lower limb aerobic exercise is not possible because of complete motor paralysis below the lesion. Aerobic conditioning is achieved through the arm crank ergometry, FES cycling, and FES assisted stepping where available. The focus shifts to cardiovascular conditioning, spasticity management, circulation, and prevention of secondary complications. Autonomic dysreflexia, monitoring and skin integrity checks remain essential throughout. Miss SM with spastic diplegic cerebral palsy, so spasticity substantially increases the energy cost of the movement. Pool walking is preferred because buoyancy reduces lower limb loading and spasticity while allowing safe gait practice. Treadmill walking with an AFO is used as tolerated. Unlike the adult cases, adherence is primarily driven through play-based and peer-inclusive activities. A lifeguard, an AEP, and a seizure management plan remain in place at all times. Same psychological system, 4 completely different exercise modalities selected to match all 4 completely different pathologies. Special considerations influenced program design just as much as pathology across all 4 cases. For Sarah, geography is the dominant consideration. Long-term AEP access is unavailable once she returns to rural Australia, so the program is built around progressive independence. The home program, community referrals, telehealth reviews, and gym orientation all act as an infrastructure for long-term self-management. As a teacher, goals are framed around occupational function, including standing endurance and stair negotiation, rather than an abstract fitness outcome. Weight discussions focus on energy and function rather than appearance, to protect motivation and reduce stigma. Potential perimenopausal fatigue is flagged with her GP, and as a mother of 3, home sessions are capped to 20 to 45 minutes and can be accumulated throughout the day. For Mr. Roberts, cultural safety is foundational. As an Aboriginal Australian man with previous negative healthcare experiences, trust, consistency, and a yarning approach take a priority over a traditional clinical interview. Goals are linked to participation with grandchildren, making exercise personally meaningful rather than medically imposed. Family and community involvement are therapeutic rather than incidental, and exercise is framed as a participation rather than treatment. Evidence supports culturally adapted interventions improving engagement in Aboriginal populations, as demonstrated by Jury and Thompson. So for Mr. Trin, autonomy is paramount. At 21 years of age with a strong pre-injury AFL identity, exercise is framed and around performance, sport, and return to participation rather than rehabilitation. And although his parents are heritage Vietnamese parents, they play a major role in his care, and a professional interpreter is used for the family communication. So Tony is never required to act as his own translator, preserving both autonomy and confidentiality. Wheelchair AFL becomes the long-term participation goal and the anchor for motivation throughout the program. And so for Miss Assem, family-centered care guides every decision. A 10-year-old Jordanian Australian with Tegretol managed epilepsy, both child assent and parental consent are required. A female exercise physiologist is required for cultural and religious reasons, and exercise is play-based and linked to school participation to maximize peer inclusion and developmental appropriateness with her upcoming SEMLS surgery planned. So which strength optimization becomes a concurrent priority alongside functional goals. So across all 4 cases, pathology explains the impairment, but cultural, personal, societal, and environmental factors determine how the program is determined. These 4 cases demonstrate the same exercise, whether sit-to-stand or aerobic training, can require completely different rationales, modalities, progressions, monitoring strategies, and safety considerations, depending on both pathology and the individual. So for Sarah, demyelination and fatigue drive decision-making. For Mr. Roberts, motor relearning and cultural safety are paramount. For Mr. Trin, autonomic instability and athletic identity shape prescription. For Ms. Assem, spasticity, developmental stage, and family-centered care guide every intervention. The pathology explains the impairment, but the person determines how the program is delivered. Effective neurological exercise prescription is assessment-driven, evidence-based, and person-centered. These principles are not applied after a program is designed. They are embedded in every clinical decision from the initial assessment to long-term self-management and discharge. Thank you.